For the purpose of this module, peripheral blood smears are the recommended method of determining red blood cell morphology. Live blood cell analysis is another method using dark field or phase contrast that can identify red blood cell morphology. However, this method is highly subjective to interpretation due to the training or lack thereof in the identification and analysis of red blood cells. In this module, red blood cell indices will be reviewed in correlation to red blood cell morphology. Variations in the indices indicate the probable presence of altered structure causing altered function of the red blood cells. Red cell indices, MCV, MCH, and MCHC are calculated from hemoglobin, hematocrit, and the red blood cell count. Most clinical laboratories now use automated machines to perform the blood cell counts, commonly called CBCs, that include the indices as part of the profile. Variations in the size of the cells, or anisocytosis, can be quantified and expressed as the red cell distribution width, or as the red cell morphology index. MCV defines the size of the red blood cells. MCV is an average value and does not reflect the heterogeneity or the presence of different cell populations. MCH quantifies the amount of hemoglobin per red blood cell. MCHC indicates the amount of hemoglobin per unit volume. In contrast to MCH, MCHC correlates the hemoglobin content with the volume of the cell. It is expressed as grams per deciliter of the red blood cells or as a percentage value. MCH was introduced to show how completely the erythrocyte space was filled with hemoglobin. As a hypochromic anemia becomes more severe, the red blood cells show a striking variation in size and shape. RDW represents the coefficient of the variation of the red blood cell volume distribution and is expressed as a percentage. Errors in the lab setting. In red cell aggregation, 2 to 3 aggregated red blood cells are counted as one, and larger clumps are not counted as red blood cells at all. This leads to a decrease in the red blood cell count and falsely elevated MCV. Determination of the hemoglobin values is not affected. The presence of immunoglobulins and fibrinogens precipitated by low temperatures in the blood sample leads to interference with cell counts, resulting in spuriously increased white blood cell counts and sometimes small elevations in hemoglobin, hematocrit, red blood cell count, and a slight decrease in MCV. Red blood cell indices miscalculations. When the values of the hemoglobin, red blood cell count, and MCV are affected, MCH and MCHCs also become abnormal since these indices are calculated and are not directly measured. In hyperglycemia, red cells are transiently hypertonic in relation to the isotonic diluting fluid, resulting in swollen cells and an elevated MCV. Hemoglobin is quantified based on its absorption characteristics. Conditions such as hyperlipidemias, hyperbilirubinemia, a very high white blood cell count, and high serum protein can interfere with this measurement and result in falsely elevated hemoglobin values. Constant demand on the immune system through chronic inflammation and infection, autoimmune dysregulation, or constant immune stimulation through nutritional support or bone broth consumption fatigues the bone marrow beyond its capacity to maintain supply and demand. This bone marrow fatigue results in the replacement of bone marrow cells through edema as the cells are replaced with fibrotic tissue. The main myeloproliferative disorders share several similarities, such as hypercellular marrow, an initially high white count, and splenomegaly. But there are several distinct morphologic and clinical differences too. Take chronic myelofibrosis, for example. In this disorder, the myeloid cells proliferate like crazy early on. If you look at the blood and bone marrow at this early stage, you'd see a high white count and a hypercellular bone marrow, features common to all myeloproliferative disorders. But as the disease progresses, the marrow becomes replaced by fibrous tissue. The white and red blood cell count eventually decreases, being unable to maintain the demand. The hemopoietic precursors have nowhere to grow, so as they start setting up shop outside the marrow in places like the liver and spleen, the spleen in particular becomes enlarged. You can see evidence of the marrow fibrosis and splenomegaly in the blood if you look closely at the red cells. In squeezing through the tight fibrosis in the marrow and in navigating through the markedly enlarged and cellular spleen, the red cells take on an unusual teardrop shape. You can almost see how they drag themselves through the tight spaces, stretching their bodies into elongated, pinched shapes. Another word for these teardrop shapes is dacrocytes. While not specific for chronic myelofibrosis, as they can occur in any case of marked splenomegaly or marrow replacement, if they are present in large numbers and the clinical setting is right, teardrop-shaped red cells are strongly suggestive of chronic myelofibrosis. Dacrocytosis can be associated with a type of anemia commonly caused by bone marrow fatigue and fibrosis. Bone marrow fibrosis is associated with numerous causes, including myeloproliferative diseases, chronic inflammation, autoimmune disorders, and endocrine disorders. Autoimmune myelofibrosis is associated with collagen vascular disease, in particular systemic lupus erythematosus, or SLE. This bone marrow failure predates the diagnosis of SLE or SLE-like diseases and develops during the course of the diagnosed disease. The most important indicators are the presence of dacrocytic anemia is low hemoglobin, hypercatabolic symptoms, including profound fatigue, night sweats, low-grade fever, leukocytosis or leukopenia, circulating blast cells, and red blood cell abnormalities, low platelets, and elevated LDH. The bone marrow fibrosis improves after a course of corticosteroids or anti-inflammatory therapy. Anisocytosis is a medical term meaning that a patient's red blood cells are of unequal size. This is commonly found in anemia and other blood conditions. False diagnostic flagging may be triggered by an elevated white blood cell count, agglutinated red blood cells, red blood cell fragments, giant platelets, or platelet clumps. Elevated RDW helps provide a clue for a diagnosis of early nutritional deficiency such as iron, folate, or vitamin B12 deficiency, as it becomes elevated earlier than other red blood cell parameters. Elevated RDW provides a clue for anisocytosis, which is the presence of multiple red blood cell size. Since other red blood cell indices, MCV, MCH, and MCHC, reflect the average values, it may not adequately reflect red blood cell changes where mixed red blood cell populations are present, such as dimorphic red blood cell populations in sideroblastic anemia or combined iron deficiency anemia with decreased MCV and MCH, and megaloblastic anemia, increased MCV. A peripheral blood smear can help you confirm the above findings in these circumstances. Anisocytosis with normal to slightly elevated RDW is associated with different levels of MCV. Low MCV with normal to increased RDW levels indicates anemia of chronic disease or thalassemia. Despite having normal MCV with normal to slightly elevated RDW, can still be associated with blood conditions such as poor iron utilization, blood loss, enzyme defects, hemolysis, or liver dysfunction. While normal RDW on the high side with high MCV may indicate liver dysfunction or developing bone marrow dysfunction with an impaired blood cell manufacturing. Where the fact of the matter is, if the patient is reporting fatigue, brain fog, and muscle aches and pains, yet their red blood cell indices are not significantly out of range, the assumption is that the blood cells are being properly manufactured until it gets to the point where the indices are finally severe enough to be out of range. But most never get to this point. Their body functions just well enough that they are able to muddle through the day, and since the shape of their red blood cells is never looked at, altered structure causing altered function is never considered as a contributing factor to their chief complaints. Anisocytosis is identified by increased RDW and classified according to the size of the red blood cell measured by MCV. According to this, it can be divided into anisocytosis with microcytosis, indicating iron deficiency, red blood cell fragmentation, and how many times do you consider the possibility of fragmentation in analyzing patient lab tests. Anisocytosis with normal MCV is associated with early iron, vitamin B12 or folate deficiencies, dimorphic anemias, sickle cell disease, chronic liver disease, myelodysplastic syndrome. Another possibility is that the body is attempting to compensate with the bone marrow working overtime and the indices appear normal. One should ask, does the patient's symptoms match the lab test? If they do not, this is something to consider. Anisocytosis with macrocytosis is a folate or vitamin B12 deficiency, autoimmune hemolytic anemia, could be associated with cytotoxic chemotherapy, chronic liver dysfunction, bone marrow fatigue, or myelodysplastic syndrome. Target cells, also known as podocytes, are red blood cells that have the appearance of a shooting target with a bullseye. These red blood cells appear as normal-sized RBCs, but with a larger than normal central pallor and a darkly stained lump appearing in the middle. This is a central concentration of hemoglobin surrounded by a colorless area with a peripheral ring of hemoglobin. These cells may be bell or cup-shaped. They are often referred to as Mexican sombrero cells. Target cells are present in most iron-deficient anemias. Target cells are found in peripheral blood films in a number of conditions. The most common conditions are liver dysfunction and the presence of variant hemoglobins. The spleen should remove excess cell membrane from red cells. Target cells form when the spleen is not removing the excess membrane. Patients with possible target cells present have very low HDL cholesterol and high triglyceride levels, high free cholesterol, and low cholesterol ester levels combined with low hematocrit and hemoglobin. Cholesterol and cholesterol esters are more similar than they are different. However, when considering their similarities, several distinctions begin to arise. Cholesterol esters are derived from cholesterol itself. Though both are considered sterols, a subclass of fat, cholesterol esters are formed when the body produces enzymes to produce a metabolic reaction with the cholesterol itself. Cholesterol is the central steroid compound that forms every cell membrane and tissue in the body. It also plays a key role in the metabolic function and hormone production. In order to perform its vital roles, however, cholesterol must be transported to the cells via the bloodstream. Cholesterol esters serve to aid in the absorption of the cholesterol so it is properly delivered to the cells. For cholesterol to achieve a specific cellular maintenance routine, it must pass into the cells from the bloodstream. Cells only take in free cholesterol, that is, cholesterol not bound to esters. However, when cholesterol is released from cells, it is most likely in the form of cholesterol esters. Cholesterol esters appear to play an important packaging role in the passing of cholesterol between HDL and LDL lipoproteins. These two lipoprotein particles are responsible for shuttling cholesterol between the cells in the liver. Target cells are thought to have a normal lifespan, but acanthocytosis in liver disease is associated with marked hemolysis and predominant splenic destruction. Red blood cell clumping or sticking together occurs in different levels of reversibility. Rouleau formations are the most reversible, and restoration of blood flow breaks them apart. Aggregation occurs with larger rouleau formation. Decreased blood flow, associated with vasomotor ischemia, and increased fibrinogen diminishes the red blood cell aggregation's ability to break up, even when blood flow increases. When the red blood cells irreversibly clump together, it is known as agglutination. Agglutination in the blood occurs when red blood cells clog together in the blood vessel. It stops the circulation of blood to various organs of the body, resulting in their dysfunction. Red blood cells aggregate face to face to form long, cylindrical, straight chains, and sometimes branch chain structures called rouleaux. When rouleaux grow large, they may contain rings or loops and take on the appearance of a network. In a vessel wider than the major diameter of the red blood cells, the branching of rouleaux is prominent and is an important determinant of their kinetic behavior. Symptoms include fatigue, shortness of breath, stress on the heart, cold hands, cold feet, poor circulation. Red blood cells shed oxygen and ATP when experiencing turbulence. During rouleau formation, oxygen is released, making the red blood cells hypoxic and the area around the rouleau formation hyperoxic, leading to the formation of reactive oxygen species. The reactive oxygen species damage the epithelial lining, requiring cholesterol plaque formation to patch the damage. Oxidation of LDL cholesterol is induced by free radicals produced by macrophages, epithelial cells, or smooth muscle cells. In addition to its participation in the formation of foam cells, oxidized LDL cholesterol appears to contribute to atherogenesis in three other ways. 1. It has cytotoxic properties that may promote epithelial injury. 2. It acts as a chemoattractant for circulating monocytes, leading to their increased accumulation with plaques. And 3. Oxidized LDL cholesterol inhibits egress of macrophages from plaque formations.